Okay, so this will be the last presentation for material on exam 2. As you know, next Monday we have an exam. It's come fast at you, I know. The first exam was a little bit slow in coming at you, in part because of the holiday, that little blip, and because I wanted to make sure everyone had been through the Lab 2 content before we had that exam that included pH and some chemistry things. The second exam will cover chapters 3, 4, and 5. Chapter 3 has been kind of going on for a long time. Chapter 3 was on the cells and on the organelles and on cell cycle and mitosis and meiosis and transcription and translation. We spent a lot of time there, actually like 2 lectures plus, dealing in chapter 3. Chapter 4 is on the histology. I'll be finishing up that today. Last time we talked about the epithelial tissues, and I got started on connectives. It'll be a review of what you've already seen in lab. Then I'll introduce muscle and nervous very briefly. Finally, today I'll finish up with chapter 5, which is on the skin. And it's a relatively straightforward, easy to start system. And if I do get cut a little bit short on chapter 5, I will take those questions out of the exam. So wherever I get today is where the exam content will finish. I did just a moment ago, or this afternoon, extend a couple of the homework assignments. I realized that I had the homeworks due like on the same day we were talking about it. So I kind of pushed things over just a little bit. If you look at your master and calendar, it's actually friendlier. It's not anything worse. And I pushed a couple deadlines out just to make it a little bit easier to get everything done after I talked about things. There's still going to be a quiz that will be due next Sunday before the exam on Monday to help you get ready for the exam. So definitely look for those 3 homework assignments, chapters 3, 4, and 5, and look for a quiz that will help you prepare for the exam in total. Remember also on that exam there's a short written portion, and that was the 10 words, using them in 3 sentences. And those words I'll give to you again, and if you have any questions on that, let me know. Vocabulary in this exam, 21 through 40, is that correct? And last time I went through 10 terms with you, and I'll pick up with the other 10 now. Any concerns, questions? That exam will be 4 o'clock on Monday. That's all we'll do here. Those who are listening from hybrid land, schedule that exam in the testing center for Monday. I believe the testing center is open a little bit later on Monday, so they have a little bit more flexibility. Any questions for me? Housekeeping or what's on the exam? Questions on transcription, translation, cell cycle, organelles, anything of that to clarify, or histology? Okay, let's take a look at vocab. So I think, honestly, the vocab gets easier. As we go through the list, more of the words are words that we've already seen in some way, or maybe have some connection with something you already know. So I honestly think the vocabulary gets easier. Remember, the vocabulary is not cumulative. It'll still just be these 20 slides, 21 through 40, not going backwards. So X and exo, meaning outside. We've seen extracellular matrix, we've seen extracellular, exocrine, all meaning outside. Extra also means outside, extracellular. So you can make, X, exo, and extra all on one slide. Why make 3 cards up? Fasci. We're going to see when we get to the muscle and when we get to nerves that some tissues are bundled together in like a band or a bundle called a fascicle. So that'll make more sense when we get to that content. If you are febrile, you have a fever. So F-E-B-R, fever. Ferent, to carry. Afferent, we saw AF, it means toward. So afferent is to carry something toward. Typically, when we get to the nervous system, we'll talk about nerve signals coming from the outside going toward the brain, afferent. Fibro, fibers. We've seen fibroblasts, cells that make fibers. Those are the cells that are making dense regular and dense irregular connective tissues. Fizz, a split, or a slit, either one. A fissure is a slit or a split going down something. And then flux, flow, reflux, to taste it again, right? Reflux. 4, in lab, this week you saw a lot of foramina, foramen. 4 means an opening. Form, in the shape of or resembling. Fusiform, no, that's not the one. Fusiform, though, is a shape of some cells, and nothing else is coming to mind right now. Fove is a pit or a little depression. In the eye, there's a little fovea. On the femur, there's a fovea. We didn't learn it this semester. And then gamo, marriage or union, monogamy. or gamete. You know the word gamete, right? Those are the sex cells, egg and sperm, and they come together. There's a marriage of those to form the zygote. Ganglio, doesn't make any sense yet. It's a ganglion. It is a term we'll see in the nervous system. Gastrostomach, that one may be familiar to you. Genesis, the production of or the origin of something, and genic, also the same thing. So if something is carcinogenic, it causes cancer. Pyogenic bacterium would be one that can form pus. Pyo means pus. Gero, maybe you've seen progeria. That's a disease where people age early, prematurely, progeria, or geriatrics, the study of aging. And then gest, during pregnancy, a woman during gestation is a time during which the baby is being carried. Gingivo, the gums, gingivitis, inflammation of the gums, and glia, glue. I know I have my examples there reversed. So glia means glue, and there are these cells in your nervous system called the neuroglia that kind of glue your nervous system together. Glom. When we get to the kidneys, we'll see a ball of capillaries called the glomerulus. So glom means ball. Glossotongue. If you're taking a medication and it says to take it hypoglossal, it means put it under your tongue and let it dissolve. Gluten. Gluten is, gluten-free. Gluten is the glue, if you will, that holds our bread products together. And glyco, sugar. We've seen glycolysis, glycolysis, sugar or sweet. Nausea, knowledge. If you have prognosis, if someone gives you a prognosis, right, you've just been maybe diagnosed with a condition, and you're asking for your prognosis. They're kind of like guessing, right? They're looking in the future and saying, we anticipate this for you. So it's knowledge in advance. Gonads are your sex glands, the testes and the ovaries. Gran, we'll see that term today. In the skin, there's a layer called the stratum granulosum, and it's in there. There's little granular, little particulate layers that you can see. Gram and graphy are both some sort of recording, a radiograph, a micrograph. Gravido is pregnancy. If you go to the doctor, ladies, it might ask for the number of pregnancies. There might be something about gravido next to that. And then gyne, again, for the ladies, gynecology, the study of reproductive and female issues. Your hallux is your great toe. So your big toe is called the hallux. Haplo and hapto, we've seen that already. Haploid was a cell that only has one copy of the chromosomes. That would be like the egg or the sperm. And what process makes haploid cells? Not mitosis, but meiosis, right? That's the process that makes those haploid cells. Hemo and hemato both mean blood. You saw that in lab this week. Hematopoiesis was the formation of blood cells in the bone. And hemi means half. Hemiplegia would be the type of paralysis someone has after a stroke, perhaps, and half their body, maybe the left side or the right side, is partially paralyzed. Hepatoliver, hepatitis, inflammation or disease of the liver. Be careful, hepato and hemato, right? Hemato is blood, hepato is liver. Hetero, different. Histo, we know histology is the study of tissues, and we'll finish up with hystero. Hystero, uterus or womb. Hysterectomy, the removal of the uterus. And proof, guys, that only women can be hysterical. Ta-da-ta. Okay. Now, that's our vocab, right? Through hystero. And we'll pick up with holo next time. So we'll stop there. Any questions on vocab? You know what to expect. That'll be a short written part on the exam. You've got two short written parts. There will be the vocabulary. Just like we did last time, I'll give you a word. I'll take these same words and I'll rearrange them in a different way. You can do the same thing with yourself. Lay your note cards down and just pick up two words and say, could these possibly be put together and what would it mean? And that's really a great way to approach the vocab. And then the 10 words, right, in 3 sentences. Those would be the two kind of short answer written portion. Everything else would be multiple choice or visual, things off the screen. Last time you saw some PowerPoint images. There will definitely be some histology this time. So different images. But the histology images I'll show you will be very similar, if not exactly like, the ones I've shown you in the histology section. So it's kind of a kind, gentle introduction to histology. Last time we got through all the epithelial structures. Really the only thing that was new in the histology section in the epithelial section, I should say, was glands, right? We talked through the different epithelia, and then I spent a little bit of time on merocrine, holocrine, and apocrine glands. That's really the only thing that was brand new from lab. The other tissues were the same ones that you were quizzed on this week. And then we talked also about the connectors, right? There were the cellular connectors, there was the tight junctions, adhering junctions, desmosomes, and gap junctions. Those are the four things that hold those epithelial tissues tightly together. So really, those are the two brand new things, the intracellular junctions and the glands. The other histology, hopefully you feel pretty comfortable with. As we finished up last time, I was just getting into connective tissues, and we got down to the definition of connective tissues, and this is where we stopped. Remember that blood, fat, cartilage, bone, tendon, ligament, all of those are of the same family, because the definition of a connective tissue is one that has loosely packed cells. That means there's lots of space around those cells. That space is called the extracellular matrix. And the part of that is called the ground substance. That's the liquid or the solid portion. And then in that ground substance, there'll be protein fibers. Remember, we've talked about collagen, elastin, and reticular fibers, and they each have a different purpose. Collagen giving strength, elastic fibers giving elasticity or stretch, and reticular fibers sort of creating a framework or a scaffolding. Now, you've also seen lots of different kinds of cells. In the epithelial tissues, they were all just epithelial cells, weren't they? We did see some goblet cells, right? Other than that, they were all pretty much the same kind of cell. They just had different shapes, right? Columnar, squamous, or cuboidal. In the connective tissue, you've got a different cell type for almost each of the tissues. So you've got fibroblasts, you've got osteocytes, you've got chondrocytes, you've got adipocytes, right? You've got a number of different kinds of cells. In the blood, you've got red blood cells and white blood cells. This is not an exhaustive list, but I want you to see that there are different types of cells that make up your connective tissues. Now, some of those cells are said to be resident cells, which basically means that once they once they set up residence, they're stuck. They don't move around. So, for example, your fibroblasts, if they're making your dense, regular connective tissue, they're stuck there. Your adipocytes are stuck in your fat tissue. And there are other cells that are stuck. But then there are some cells that wander around. Think blood, right? Your red cells and your white cells, they wander around. They wander. So they're called wandering cells. And they're going to wander around to help you out. So your white cells are going to wander around looking for infection to destroy. Red cells are going to wander around delivering oxygen. Other cells are going to wander around and, again, help in some purpose of your body. You've already seen this as well. This is review. 3 types of protein fibers: collagen, elastin, and reticular. This just recaps that for you. Collagen is by far the most abundant protein in your body. It's a major player in your bones, and it's a major player in other structures as well. So lots of collagen in your body. There's also quite a bit of elastin. If you think about elastin, think of your nose, think of your ear, tissues that are rather squishy. There's quite a bit of elastin even in your skin, right? Your skin is quite flexible. And then those reticular fibers. Reticular fibers are actually another type of collagen. They give you strength, but they're more like a meshwork, right? More like a scaffolding than they are giving tremendous strength. So in that table I showed you, as we finished up last time, I told you that connective tissues are broken up into loose and dense, right? And structural and liquid. And so the loose connective tissues, what that basically means is that the cells, they're always loosely arranged, but here even the ground substance and the proteins are rather loosely arranged. There are 2 loose connective tissues that you know how to recognize. One, areolar. That's that loose areolar connective tissue. I'll show you a picture of it in a moment. It's the one that looks like confetti, right? Loosely arranged, very loosely arranged fibers. And then fat, adipose, is also considered a loose connective tissue. There is another one, reticular connective tissue. It is one that we crossed off in lab. I'm going to show you a picture of it in a moment. You're not responsible for it. Okay? I'm just going to include it for the completeness of the experience. But you do not need to recognize reticular. you need to recognize the same 6 structures here that we did in lab. So here is an example of loose areolar or just areolar connective tissue. I showed you the same image in lab. It's that loosely arranged kind of confetti look. The cells are fibroblasts, and the strings that we're seeing are a combination of elastic and collagen and reticular fibers. The space in between all the cells would be considered the ground substance. And this stuff is everywhere. It really is. But there's a nice layer of it in the dermis. So if you wanted to, tack a place where this is found in the body is the dermis. And I'll get to that in a few minutes. When I talk about skin, I'll mention the dermis and I'll mention this being there. Adipose, you've already seen it. You know how to recognize it. The cells are the adipocytes. Not only are they providing padding, but they're also, in protection, they're also storing energy. So, there's more than one purpose for these tissues. And then reticular fiber. Not have to memorize it, but doesn't that kind of look like chicken wire in a kind of way? So it just kind of has this reticular scaffolding look. Don't worry about where it's found. Don't worry about recognizing it. Then there are the dense connective tissues. One of these you need to know. Dense regular. I'll show you a picture of that. The other two, don't need to know how to recognize them. Here's dense regular. This is a slightly different picture than what you saw in lab, but I kind of like it. Those wavy lines you're seeing, the wavy lines are all the collagen fibers, and the collagen fibers are all tightly arranged, right? Stacked on top of each other, very, very tight. The dark purple that you're seeing are the nuclei of the fibroblasts. So the fibroblasts are the cells making the fibers, makes sense, fibroblasts, cells that produce or bud or make fibers. Remember that dense regular connective tissue is almost, not completely, but almost avascular, so it doesn't heal very well. And under the microscope, on the models, dense regular connective tissue, your tendons and ligaments are very white, aren't they? And they're white because there is no blood. Muscles kind of red because there's a lot of blood. Tendons and ligaments are very white because there is little to no blood flow. Here's dense irregular. You don't need to know how to recognize this one, but I do want you to know this is also a major component in your dermis. So when I get to skin in a few minutes, I will say this layer. So you need to know about this layer, that it's in the dermis, but you do not need to recognize it. And then finally, there is elastic connective tissue. Kind of looks like a rubber band, doesn't it? Again, you don't have to recognize it, but this stuff does exist in your body, especially in things that really stretch, like some of your arteries, in the penis, in the vocal cords. There's quite a bit of this elastic connective tissue. Then there are supporting connective tissues. These are the ones you know well, cartilage and bone. Cartilage, the cells that make up the cartilage are the chondrocytes. You've seen them before. The cells that make up the bone are the osteocytes. They are hard to semi-solid connective tissues, and their extracellular matrix has quite a strong amount of collagen in it, making it semi-solid to solid. As we've already said, cartilage, let's focus on that for a moment, is sort of a semi-solid gel-like substance. Those chondrocytes are in the lacunae. It's more flexible than bone. Cartilage is definitely more flexible. The tip of your ear, your nose is made of this stuff. And as we've said before, mature cartilage is avascular. There's no blood flow in mature cartilage. It is covered by a layer called perichondrium. What do we find surrounding bone? Periosteum, right? So periosteum is around bone, perichondrium is around cartilage, and there are in fact 3 different types of cartilage, only one of which you need to know, and that's hyaline. The other 2 I'll mention. Fibrocartilage, I'll say now, is the type that's found in your knee. Fibrocartilage is a type that's found between your vertebrae. It's a very tough, weight-bearing kind of cartilage. Hyaline cartilage is the one that we have to look at, and here's a picture of that. You saw the same image in your quiz this week. So this is chondrocytes hanging out in lacunae in this eyeball-looking structures, right? The eyeball-looking cells. This is, again, the cartilage you find at your articulating surfaces. You know what that word means now. This is the humerus going into the scapula. You see that white end on the humerus. when you're going to B-dubs and you get some chicken wings, right, and you pop out the bone and you see the nice little white circular structure, that is the cartilage on the joint space. That is hyaline cartilage. If you could take that little layer of hyaline cartilage off, you would see that it's rather transparent, kind of glassy, and that's where its term comes from, hyaline. Now, there is fibrocartilage. You don't have to recognize it, but you still have the same thing. It's still chondrocytes living in a lacuna, but now you can see those wavy lines, and those wavy lines you can imagine are collagen. So this is just a tougher kind of cartilage. And again, it's found in the discs between the vertebrae. And then finally there is elastic cartilage. This is the kind of cartilage that makes up your ear. Right? This is why, remember, cartilage is avascular. This is why people can poke funky things in their ear, right? Up in the cartilage regions, and it doesn't bleed, right? So there's pretty much avascular, and it's flexible. Again, you have chondrocytes hanging out in lacuna, but the fibers out here are now not as much collagen, they're now more elastic, so more stretch to it. Then there's bone. You know the most about bone. You know that bone is made up of collagen and made up of calcium and phosphate salts. It is covered by a periosteum, and there's two types of bone. You saw them in lab. The outer layer with the osteons that we learned a lot about is the compact bone. On the inside, there's spongy bone. That is where the bone marrow is and where the blood cells are being made, or where the process of hemopoiesis is occurring. You know that the compact bone has osteons with lamellae and a central canal and canaliculi. So that's all just review. Does this feel pretty comfortable? Hopefully. Right? You've already had a quiz on this, a lab on this. You've studied for a quiz. So hopefully this is all looking pretty comfortable. This picture you saw in the lab quiz, this is bone. You're looking at an osteon structure, and you know about the central canal. You know about the canaliculi. You know that what you're seeing in this image are some layers, right? And those layers are each called a what? Each layer? Lamellae, right? And the central canal in the very center. Central canal. The whole round thing is the osteon. And we have osteocytes in a lacuna connected through little squiggly lines called canaliculi. This is just an artist's rendition of the same thing. So this is the actual image, and then this is the artist's rendition. And sometimes these artist renditions are easier to look at because they really highlight the structures. So here you can more evidently see the layers. You can really see, in these cartoons, you can really see the lamella, and you can really see the canaliculi. A little easier. And then there's one and only one fluid connective tissue, and you know that's blood. The cells there are red cells and white cells, erythrocytes and leukocytes. There's also little things called platelets that are involved in blood clotting. We'll spend a whole chapter talking about blood next to the chapter on the heart and blood pressure. Okay, so there's a picture of blood. That was not on the quiz this week, but I think you all recognize all those little spheres are red blood cells, and the bigger, darker staining cells are the white blood cells. Now, this is a good time for you to mention membranes. You've learned about membranes from me. You've heard about serous membranes. That's a term you definitely heard in Lab 1. There are also mucous membranes. Now, in anatomy, a membrane is sort of code word for an epithelial layer. So if you hear about a membrane, it's really just an epithelial layer. So the mucous membranes are epithelial layers lining things that enter into our body, your oral cavity, down your gut tube and out the anus. All of that is lined by a mucous membrane. And there's a lot of mucus being made by goblet cells along those layers. So there's mucous membranes. Now, mucous membranes, like I just mentioned, have an opening to the outside world versus serous membranes. Do you agree that serous membranes, I can't take my finger and touch them? Right? I can touch your mucous membranes, but I can't touch your serous membranes. Those are the membranes that surrounded your heart, your lungs, and your gut organs, the peritoneum. You already know about the serous and the parietal layers. Another way of thinking about it, mucous membranes, any place where if you put Tabasco sauce, it's going to burn, right? So that's going to be your mucous membrane. So inside your eye, inside your mouth, inside your nasal passages. If you take Tabasco and put it on your arm, it's not going to hurt, right? It's going to burn only on those mucous membranes. Then the third type of membrane is what we'll be talking about today, and that's cutaneous membrane. That's just a fancy word for your skin, right? Subcutaneous, under the skin. And the last one is one we'll get to in a few weeks, and that's synovial membranes. These are the membranes that are found surrounding some fluid compartments in your joint spaces. So in the knee, in the shoulder, there's synovial fluid, and that synovial fluid is surrounded by a, quote, membrane. Again, fancy word for epithelial layer. So everything I've set up to there is kind of review. I've added a few more facts and features about epithelial and connective tissues. I want to spend the last few minutes on histology introducing you to muscle tissue. We have not yet looked at it in lab. Next week we will. Next week we'll be learning some muscles in the body. We will take the microscopes out. You will see muscle tissue again. The images that I'm going to show you on the lab exam, on the lecture exam will be exactly these images. So let me introduce these to you. You're not going to be as familiar with these as you are the epithelial and connective tissues. Muscle tissue is unique in that it changes shape. That's what's special about muscle, is that it contracts. Muscle can be either voluntary or involuntary, simply meaning you either have control over it, voluntary, or you don't have control over it, involuntary. For example, your heart is involuntary. You don't think about your heart beating, it just happens for you. Your brain takes care of things for you. Muscle is all over the place. It's definitely involved in your breathing, involved in your blood circulation. It's involved with pushing things through your digestive tract. It's involved with your digestive system. Pretty cool stuff. Now, 3 types of muscle. There's skeletal muscle. This is the kind of muscle attached to your skeleton, attached to your bones. This is also the muscle type over which you have control. So when you decide to pick up something or walk or move, you are telling that muscle to move your skeleton. It is voluntary. I'll show you a picture of it in a moment. The second type of muscle is cardiac muscle. This muscle is found only in the heart, as the name suggests. It is an involuntary muscle. You do not have control over it. Thirdly, there's smooth muscle. It's also called visceral muscle. So that should kind of tell you where it's found. It's found around your viscera. This is the kind of muscle around your intestines, around your stomach, that's helping to push food through your gut tube. Again, it's involuntary. You don't wake up and think about pushing food through your digestive system. You do think about defecating, but that's voluntary again, right? So as you open your mouth and put food in, that's voluntary muscle, right? You're chewing, you're opening your lips, you're swallowing. But the moment you swallow, that food is now traveling through involuntary muscles. It's going through smooth muscles. It's being pushed through your digestive system. And then at the very end again, hopefully you have control again, right? So then we get to the very end, and we have control of defecation at the rectal muscles, and those are back to being skeletal muscles. Let's take a look at these. Now, I want to do the same thing I did with you in lab. I want you to look at this and just tell me what you see. And then I want you to write that down so you have a visual kind of a story that you're telling yourself. What do you see when you look at this image? And this is exactly the image I'll show you next week on Monday. Okay? So what do you see? I see tire tracks. I like the tire track idea. Or really gaudy striped pink bath wall, wallpaper. Bathroom wallpaper. But I like the tire tracks because in order for someone to have left tire tracks behind, somebody had to have, quote, stepped on the gas, right? So to make tire tracks, somebody had to voluntarily step on the gas and move the car. So that will kind of help you bring it all around. What you're actually seeing, and I'll tell you more about it when we get to muscle and when we get to the muscle lab, you're actually looking at only 3 or 4 cells here. There's one cell. It's a very long cell. It goes from edge to edge. And then here's another cell up here, and here's another cell down here. Now, the other thing that we notice, why you said tire marks, is that this muscle is said to be striated. And striation is a word for these stripes that we're seeing. So this is a striated muscle, those stripes. Okay? And we'll figure out what those stripes are when we get to muscle in a few weeks. For now, just recognize the tire tracks. Number 2, This is cardiac muscle found only in the heart. What do you see?
It's like
Tree?
like the knots.
Knots in a tree? You're getting closer to what I see. I always imagine that I see bamboo.
Like a bark.
Do you see shoots of bamboo? And these shoots of bamboo even have those little hatch marks that are in bamboo. Do you see bamboo with me now? Okay. Now, what kind of animals eat bamboo? Pandas, and we all love pandas. Cardiac, love, bamboo. It all kind of goes together in a weird way. So if that makes sense to you, it's weird. But if you see the little bamboo-like structure, and in this case, in this image, it's a blue stain. In our lab next week, we'll see pink. But in this particular image, it's a blue bamboo, right? And that's the cardiac muscle. Finally, you're going to see this kind of muscle. This is smooth muscle. What do you see here? I don't see bamboo, and I don't see tire marks. Tadpoles, that works, maybe. Doesn't work for my story, but if you see tadpoles, that's fine, right? But you're on the right track. I see parasites, little worms. Do you see little parasitic things? Right? It looks like a bunch of worms. Now, if you had some parasites, where would they be? In your body. They would be in your intestines. Okay. This is smooth muscle. It goes around your intestines. Right? So I see those little squiggly, parasitic-looking worms. Okay, you see them all? And those, that's actually the shape of the cell and the shape of the nucleus. So the nucleus also kind of gets elongated. So these are long, squiggly cells, little worm-shaped cells, smooth muscle. So again, those are the three that you need to recognize for next week. Very straightforward. Tire tracks, bamboo, and worms. All right, that'll get you through those pictures. And that's also involuntary. The last type is nervous tissue. And now nervous tissue is special in that it can send electrical activity really, really quick. It's the basis of your brain and your spinal cord. And there's going to be a bunch of neurons and nerve cells that are going to make this work. We'll spend 4 chapters talking about the nervous tissue. It will be our 4th exam. So the second exam coming up, 3rd exam will be over muscles and bones. The 4th exam will be over the nervous system. So we'll have a lot of time to talk about the cells of the nervous system. And the one thing I want you to know is that these are the longest cells. Some of the cells in your nervous system are some of the longest cells in your body. These cells can go all the way from your spinal cord all the way down to your big toe. Okay, so in a guy my height, that can easily be 3 feet long. So these cells, I know that up till now, in our conversation of cells and organelles, you were labeling parts of a little spherical cell. And it had a little purple nucleus and a green Golgi, right? And little orange mitochondria in the cartoons. But I want you to also realize that not all cells are little spherical things. You've already seen columnar and cuboidal and squamous cells. So you know that epithelial cells can have different arrangements, but neurons are amazingly different. Muscle cells are also very long. Muscle cells are as long as a muscle is. So, for example, biceps brachii, the muscle in your upper arm, the cells are as long as the muscle. So again, they can be quite long. You've got some muscles in your leg that are a good 18 inches long. Those muscle cells are also 18 inches long that make up the muscle. So don't get locked into thinking all cells are spherical, little cells. The only image I want you to know for this test on Monday is this one. This is a picture of nervous tissue. It represents the cells of the nervous system. I'm not even going to introduce them to you, but this is a neuron, and it has axon and dendrites. And if you know about that, great. If you don't, I don't want to bother you with it right now. We'll get to that. But this is the image you need to have ingrained in your head for nervous tissue. Okay. Mostly found in your brain, spinal cord, nerves of your body. We'll get to all that later on. Okay? So what do we know? We've got histology. As I said on Monday, I'm very pleased overall with the histology quiz grades in lab this week. That went for all 3 groups. And I think it's because of some of the online activities. You've been interacting with this material more than students have in the past. But it does take some practice, doesn't it, to get this. And so you want to be looking at some different images in the atlas, different images on PAL, different images in your textbook, and start looking at these images so that when you see them, you'll recognize them the next time. The last thing I want to say to you is that we're talking about tissues, and tissues do change over our lifetime. And here are 6 terms about that, and this finishes up this chapter. Metaplasia is a term used to specifically describe what happens in a smoker's trachea. What kind of tissue do you normally find in the trachea, lining the trachea? That's where the pseudo-stratified columnar with the cilia are and the mucus-producing goblet cells. But smoke is a tremendous irritant to those cells, and after a while, the epithelia changes, and it loses the cilia. And it actually changes to a simple epithelium, which means, describe to me what a smoker, after 30 years of smoking, what do they sound like? They're always coughing, right? Why are they always coughing? You and non-smokers, right? So what happens? You got those goblet cells are making the mucus, and that mucus is always being released. As you take in a particulate, a virus, anything in the atmosphere, those particles get stuck on the mucus, and they're constantly being brought up, and you're kind of swallowing that all the time, right? And you're swallowing all that stuff all the time. In a smoker, you lose the cilia. The goblet cells are still there, but they're no longer pushing that mucus up in a regular way. So that mucus accumulates, and all of a sudden now they're hacking these big globs, right? So they got the mucus, but they don't have the cilia constantly bringing it up, so it tends to accumulate. Right? So they're hacking up these big globs of mucus. And because the cilia aren't there, the particles, the smoke particles, and the irritants tend to make it all the way down into the lower part of the airways. And so after 30 years, we call that cancer, right? So those particulates get all the way down into the alveoli, irritate and mutate those cells, and cause lung cancer. So metaplasia is a kind of change that occurs with smoking, as an example, to the tracheal cells. Then there's hypertrophy, hyper trophy size, right? So if you ever got a trophy, you want a bigger trophy, right? Bigger trophy, bigger size. So hypertrophy is an increasing in size of cells that are already there. And then there's hyperplasia, an increase in the number of cells due to mitosis. You're actually dividing the cells. Neoplasia. Actually, hypertrophy is what happens when you gain weight, because we all pretty much have the same number of fat cells in our body. What changes is how much fat is stored in each cell. So as one gains weight, hypertrophy is what's happening. Those cells are changing their shape. We're not growing new fat cells, right? We're not doing hyperplasia. We're instead doing hypertrophy. Neoplasia, new growth, that's a tumor. Atrophy, when either the cell number or the cell size decreases. If you've ever had an arm cast or a leg cast, you know that when that cast comes off after 6 or 8 weeks, that your muscles have atrophied. They actually have decreased in size and in number, and then that muscle comes back over time. But you see that atrophy. Or if someone's in a wheelchair, their muscles will atrophy because they're not using their muscles. And then finally, necrosis. This is cell death due to some sort of trauma that is irreversible. This is not apoptosis. Right? Apoptosis is programmed cellular death. Necrosis is a burn. Necrosis is a wind burn, or that's what I'm looking for. Frostbite, right? Some sort of damage to the tissue that is not necessarily reversible. So necrosis, or a bacterial infection where the tissues are killed off and they die. So those terms are just really good terms to know, all related to tissues. So that does bring us exactly to the end of chapter 4. What do you think? Are you okay? Now, how many tissues do you need to know? How many total tissues have we had that you need to recognize? We had 6, right? There were 6 epithelials. Same 6 we had in lab. I showed you a few extras, but you're only responsible for the same 6. there were 6 connective tissues. Same 6. I showed you a few extras, but you're only responsible for the same 6. I did show you 3 muscle, and I showed you 1 of nervous. So that's a total of 16, right? So you really need to be able to recognize 16 different tissues for the test on Monday. There will definitely be a number of slides, much like the quiz was in lab. And that went well. Yes?
And we need to know the location of each.
Yeah, so as you're thinking about the tissues, can you name it? Do you know where it's located? Same kind of questions from lab. Do you know what kind of cells are in that tissue? Any kind of special things like microvilli or cilia or goblet cells, those little features that I mentioned in lab. Okay. Anything at all about histology? What I'm going to give you 5 minutes now, right? So when we come back, we can just go through skin. So let me give you 5 minutes now. I'll roll over to the skin lecture and go ahead and get a drink or something, stretch a little bit, and we'll go straight through the last hour and 15 minutes when we get back. So the last chapter is on the integument. This is our first system, right? Up until now, we've been doing that atom-to-atom continuum, atoms, molecules, macromolecules, organelles, cells, tissues, organs. Finally, right, we're at an organ system, the integumentary system, or the integument, which is a fancy word for the skin, the hair, and the nails. We'll be, from this point on, in systems. So chapter 5 is the skin. Chapter 6 and 7 will be skeletal. 8 and 9 will be muscular system, and on we go. So this is the level we'll be at. Everything we've been learning up to this point will sort of be foundational and will help us make sense of the things in the future. Now, this is the classic picture of the skin. You need to recognize some things about this. Let me get us started with what's important right now. And you've already seen this in lab, so it's not so bad. You know that the skin is really only 2 layers. The epidermis, and the epidermis, remember I'm drawing the basement membrane here, right? So the epidermis is everything above it. That is what kind of epithelium? Stratified, squamous, keratinized. And then the squiggly line would be the basement membrane. And then below the basement membrane, we have a bunch of connective tissue, CT, and that layer is the dermis. There is a hypodermis, right? Down below this, there is a hypodermis, but that is not part of the skin. That is actually below the skin. We would say that the skin sits on the hypodermis. So it's not officially part of the skin. It is mostly adipose. What kind of tissue do you find in the dermis? Loose connective, good. And another one that I said, but you don't have to recognize, dense irregular. Okay, so in the dermis, there's loose areolar connective tissue, and there is dense irregular connective tissue. And that kind of makes sense because this connective tissue kind of connects everything together. It's connecting the blood vessels and the hair follicles and the sweat glands and the sweat glands and the nerve endings. It's connecting all of that into this area. Now the nerve endings and stuff we'll hold off for the nervous system. Okay, so right now we're just going to deal with the layers. So hang with me as we go through this. So the integument is just a fancy word for your skin and the associated structures. This is also called your cutaneous membrane. I mentioned that a few minutes ago. There were 4 kinds of membranes in your body: mucous, serous, synovial, and cutaneous. And it's not only your skin, but also your hair, your nails, sweat glands, and sebaceous glands. Sebaceous glands are your oil-secreting glands. Your sweat glands are more your watery type secretions. So you have lots of regular sweat glands in your palm and all over your body. You have sebaceous glands, more of them in the oily areas of your face, and we don't have, thankfully, sebaceous glands on our hands. Right? We don't have oily secretions from our hands. Wouldn't that be gross? Right? We just have watery secretions. So we'll talk more about that. So the integument is your body's largest organ. It accounts for, it's a large size, up to 2 square meters, probably more on me, and is kind of thin, 1.5 millimeters, but can in some places be quite thick. Think the palms of your hand, the soles of your feet, where you may have some thicker, calloused skin. It is protective. It's definitely protecting us. There's connective tissue, right? There's the dermis. And down in the dermis is where we're getting blood vessels. So that's providing strength, some collagen, and providing the nourishment of our skin. There's definitely some muscle in your skin, smooth muscle. This is the kind of muscle that pulls the little hairs up, right? When you're scared, little hairs rise up on your skin. There's little smooth muscles in your skin that do that. And finally, there's nervous tissue. There's nerve endings in your skin. So what does this tell us from our hierarchy? Skin is an organ. Skin is made up of tissues. And if I had a chunk of skin in my hand, I could find in it a little epithelial, a little connective, a little muscle, and a little nervous. So all 4 types of tissues are combining to make an organ. If I had a brain in my hand, it'd be a different arrangement, but I would have epithelial, muscle, nervous, and connective tissues in a brain, in a kidney, in a stomach, whatever the organ is, in a bone. I would find representatives of each of those tissue types. Now, the skin, 2 layers, I already mentioned them. The top layer is the epidermis. It is made up of stratified squamous, and it's not complete, stratified squamous keratinized. And then there's a deeper layer, we know that's the dermis, and it is largely, there's the word, made up of dense, irregular tissue. There is some loose areolar also in the dermis. And then as we go deep to the dermis, there is where you find the hypodermis. That is largely adipose, but even more of that loose areolar. So again, that loose areolar is kind of everywhere. It kind of pops up in many, many places. And as this slide reminds us, the hypodermis is not a part of the integument. Our skin sits on the hypodermis. Then below the hypodermis, we start seeing muscle. So here is a cartoon representation of the layers of the epidermis. We're going to start in the epidermis, then we're going to talk about the dermis, and then we're going to finish up with hypodermis. At the end of our time today, we'll talk a little bit about skin cancer, and we'll talk a little bit about burns that can occur in patient skin. That'll be our chapter. So this represents just the epidermis. I'm going to draw on this the basement membrane. So the basement membrane is way down here. The woody-looking stuff below it, that's connective tissue, right? Kind of looks like wood. That's the connective tissue in this drawing. And there are 5 distinct layers of cells in the stratified squamous epithelium. I'll mention them now, and then I have a slide for each of these layers. The bottom layer is called the stratum layer, basale, the basal layer, the bottom layer. It's a single layer of cells. It sits right on top of the basement membrane. Then there's a layer of cells called the stratum spinosum. These are all the pink cells that you're seeing in here. So that's all stratum spinosum. Then there's a layer called the stratum granulosum. In our vocabulary today, you saw gran. It said granular or particulate kind of layer. If you look at that, you see it looks kind of dark. The stratum granulosum has a dark appearance. Again, I'll have a slide for this in a moment. Then right above the stratum granulosum is a light layer called the stratum lucidum. You can see it looks lighter in color. Lucid, light, right? Lucidum. And then the top layer is called the stratum corneum. And these represent all of the dead cells. So all those dead flaky cells at the top of your skin are of the stratum corneum layer. If you have a corn, what do you have? Sometimes painful, but a big old thick callus, right? It's just a big old thickened area of skin. That's all dead skin. It can be torn off, can't it? It's not very much fun, but you can pull off a corn, pull off a big old callus. It's all the dead cells. So I've introduced you to the layers. I should have had this slide first. What are the functions of skin? We know this. There's a couple of them here that may be a new idea for you. We know the skin is protective. Clearly, it protects us from damage, from burns, from water loss, temperature extremes. We lose already 500 milliliters of water every day to evaporation. So without the skin, we would lose even more water and would have a real difficult time holding on to our fluids. If you've ever seen a burn patient, they're going to be hooked up to an IV in the hospital to avoid to give them antibiotics to avoid infection, but their bed is soaking wet because the fluid just leaks right out of their body when you lose that skin layer from a burn. Temperature regulation. Within our skin, there's a lot of blood vessels. When it's cold outside, those blood vessels kind of go deep and hide, and you become more pale in color. On a hot day, those blood vessels dilate, they open up, they go toward the surface, they're trying to get rid of heat, and you take on more of a red color when you exercise or when it's warm out. Metabolic regulation. This is where vitamin D begins its synthesis. You must have UV radiation from the sun to make vitamin D. This is why most of us in Michigan especially are vitamin D deficient in the winter months when there isn't much sunlight. And why a lot of people take vitamin D supplements, especially in the wintertime. Now, we do have vitamin D added to our milk and to many of our dairy products, so we get away with some of this, but if it weren't for our dairy products, especially living up here, we'd be in trouble for vitamin D. Vitamin D is important for our bones. So without good vitamin D levels, our bones can suffer. Immune defense. Your skin stops bacteria and viruses from attacking, and in your skin, there are actually some immune cells that gobble up invaders. We've got our nerve endings, hot, cold, pain, vibration. All those sensations are picked up by nerve endings in your skin. And excretion, we're sweating. So we're sweating out a lot of water, but also we're losing some salts. Our sweat is kind of salty. And sebum, sebum is grease, because it's the oily stuff that releases from our sebaceous glands, right? The sebaceous glands make sebum. So those are all the good things that skin's doing for us. Now, let me go back to the layers. And I have one or so slide per layer. These facts are about the bottom layer, the stratum basale. This is the bottom layer of the epidermis. It's sitting directly on the basement membrane. And it is essentially a layer of simple cuboidal cells. So if I'm going to kind of drag this along here, it's one layer of cells. They're kind of just simple cuboidal or simple columnar in shape. There's three kinds of cells that make up this layer. Most of them are called keratinocytes. That's just a fancy word of saying cells that will someday make what? Keratin, right? No, these are cells that are going to make keratin as they move toward the surface. But there's also melanocytes here. Melanocytes are the cells that give your skin its pigment. So you'll hear people say your color is skin deep. It's not even skin deep. It's only epidermis deep, right? Because your skin, the melanin that creates pigment in your skin is in this layer, right? Your dermis, all of our dermises are the same color. It's just the epidermis that is different in color. And those are the melanocytes. And in these pictures, the melanocyte is shown as this yellowish cell right here. So there's one here and there's one here. Okay, those are melanocytes. They make the melanin. And then there are Merkel cells or tactile cells. These are nerve-ending cells. They give you the ability to feel fine things. So when you feel 700 thread count sheets, right, versus 250, very, not a lot of difference, but that silky difference, the ability to feel very fine differences, that's coming from these little nerve endings that are very close to the surface of the skin. In this picture, those are shown right here, this blue cell. And if you look, that blue cell is attached to a yellow structure, so it's a nerve ending. So those are the cells of the stratum basale. Then there's that really healthy layer of the stratum spinosum. These cells are dividing. They're very metabolically active. And as they divide, the skin is being pushed upward. In here, there's going to be a type of cell, shown here in yellow, called a Langerhans cell. This is a specialized immune cell. And if a bacterium were to get down into this layer, these cells can gobble up like little Pac-Men. So this is an immune cell that can fight against virus or bacterium or parasites should they try to get through the skin. The next layer, stratum granulosum. You know what happens to these cells. As they move toward the surface, what happens? They begin to die. And as they begin to die, they start looking rather granular. All their organelles are beginning to break down. That's what's happening here. In the stratum granulosum, what you see is a darkened layer. In the cartoon, it's this purple layer. It's not very thick, only 3 to 5 layers of cells, but in that distinct area, the organelles and the cells are dying, and they become very granular in their appearance. Stratum granulosum. And at this point, the cells have made all the keratin they're ever going to have, because the cells are dying, right? This is their last chance to make keratin. And the cells start becoming thinner. So they go from being more of a cuboidal shape, and they start becoming more squamous shaped in the layers that we see above. Oops. Then after the stratum granulosum, there is the stratum lucidum. Now, there's 2 different types of skin, thick and thin. I'll talk more about that in a moment. This layer, the stratum lucidum, is only present in thick skin. In thick skin, okay? So this is going to be, for example, the palms of your hands. I have no idea what that means. The soles of your feet, not heat, right? The soles of your feet. And this is only found there. This is a very light-colored layer. That's why it's called lucidum. If grandma is lucid, what does it mean? She still has a bright mind, right? She's right. So lucid, light. And then, as you go to the very top, the stratum corneum. These are the dead, flaky, dead layers at the top. It can be 20 or 30 or even hundreds of layers of cells if you have like a corn or a callus. These cells are lacking a nucleus. They are anucleated. And it takes about a month for your cells to move from the stratum basale up through the epidermis to be flaking off in your vacuum cleaner. So every month you've got a brand new layer of cells. I mean, constantly, right? You have a brand new layer of cells coming up through your epidermis. So that's the epidermis, okay, and the layers of the epidermis. Let me talk to you about thin versus thin skin. This is a micrograph on the right of thick skin. Let me give you, again, your bearings. My finger is going along the basement membrane. That's all. Everything you're seeing in this picture is layers of skin, layers of epithelial cells. And you can see, do you see that dark layer? Mm-hmm. Right? That dark layer is the stratum granulosum. And then you see a little light-colored layer. That'd be the stratum lucidum. And then everything above it, right? Many cells, layers of dead, anucleated stratum corneum. Again, where do you find this? Fingers, soles of the feet, palms of the hand. It can be rather thick. 5 layers, right? All the layers, including the lucidum, are here. But if you think about the bottom of your feet and the palms of your hand, you don't have hair, right? So there's a different arrangement of things. There's no hair on your palms. There's no hair on your thick skin. And you sweat differently from your palms than you do from the rest of your body. You have from your palms very watery sweat glands, from your feet as well, but you don't have the oily kind of secretions from your feet or your palms. Those oily glands are more in our face, and we have other kinds of sweat glands in our pubic and axillary regions.
I have a question.
Absolutely.
So it's like a scar of thick skin?
A scar is, as the skin is repairing itself, what you're seeing is the collagen that is part of the repair process. Now, and I'll talk about that today, sometimes a scar can be very minor. Okay, it'll have a lot to do with the angle of the incision. And sometimes the scar can be very thick. And in some people, they get even keloids, where it really overgrows and makes a really thick, big mess when you cut. But it's really just the collagen that's fixing itself. So it does become thicker, but if that scar is on your regular skin, I would not call that thick skin. I'd still call it, yeah, it doesn't have the lucidum, right. So good point. So when you scar, you're not suddenly creating a lucidum layer in thick skin. Now, on the right-hand side, that is thin skin. Okay, so it's the same image on the left side of thick skin, and over here, again, all we had over here was just this little blip of connective tissue down below. Here, I'm drawing the basement membrane. So everything down here is connective tissue. You can see side by side that there's very few cells in this layer, and you can see that the stratum corneum, the outer layer, is much, much thinner, and you can even see how, they're really flaky, dry cells. What you do not see here, no stratum lucidum. There is still a stratum granulosum, there's still a stratum spinosum, but there is no stratum lucidum. You only see that light-colored layer in the thick skin. So the thin skin is pretty much what's all over your body. And thin skin has hair, right? So all over your body, even in places where you don't have much hair, you typically have microscopic thin hair. So from the scalp, all over your body, really the only places where you don't have hair in your body, lips, thankfully, right? No hair on the lips. That's still thin skin, but there's no hair. On part of the genitals, right? There's no hair on the labia, no hair on the foreskin of the penis, and everything else pretty much hair, right? Even if it's very, very small.
Is that why some part on our skin is darker than the other, even though it doesn't face with the sun?
Yeah, I'm going to talk about freckles and some other things in a minute. Okay, we'll talk about some skin coloring in a minute. So hold on to that thought, and then we'll get there. So this is much thinner. It has hair follicles and has lots of sweat glands, including sebaceous glands. Now, why do you want sebaceous glands? It seems like why would you want oil coming out of your skin? It seems like a real trouble, right? It creates zits, it creates all kinds of problems. But yeah, you want your skin to be moist. You want it to be supple, right? You want there to be a certain amount of oil coming from your skin, not too much, but you want enough that your skin stays nice and supple. Now, let's talk about skin color a little bit. I've already alluded to this. Across the bottom are different skin tones. On the lower right, very, very pale, red hair. Then you've got different colors. We see very, very dark as well. On the lower left are siblings. So we've got a child with dark complexion with a sibling with light complexion. Now that person would be what we would call an albino or have albinism. So that's a mutation, and that person would be, depending upon the culture, in some African cultures, that child would be considered almost like a goddess, right, really special, and in other areas, they'd be hunted down as evil. And there are actually groups that try to save these kids because in those areas where they are threatened with their life because they're so different. So they're just cultural, religious beliefs that they're somehow evil. Now, again, what causes skin color? Mostly it's those melanocytes, those cells that make melanin. There's a couple different types of melanin. Melanin can be kind of yellowish. It can be kind of reddish. It can be kind of brown or tan or black. And that gives you the collection of skin color on the planet. That melanin is inherited, right? Your skin color is similar to your parents or a combination of your parents' skin color. That melanin, though, is also helpful to protect people from UV rays. People with darker complexions are at a lower risk for skin cancer. So where do you think you find the greatest risk, the greatest population with skin cancer in the world? Caucasians who live where? Near the equator. So where do you think the highest rates of skin cancer are? Historically, we see people with darker complexions along the equator and paler people toward the poles, right? So where's the highest rate of skin cancer in the world?
Antarctica. Alaska.
How about Australia? Bunch of white people who don't belong there. Northern Australia, right? It's rather tropical, right? But it's mostly displaced Europeans who are living there. So their body is Caucasian, but they're living in a tropical place, and so they're at higher risk, right? Now, that's also true of people living in Florida. Anyone, 30 years ago, before we had enough sense to put on suntan lotion, skin cancer rates were higher. Now we're learning, right, to put sun lotion on our kids and protect us from those rays. But historically, UV radiation was very damaging to people as pale as I am. Now, it's interesting that the number of melanocytes in me is the same as everybody in the room. So it's not the number of melanocytes. Those are the same in all of us. What differs is or are the melanocytes making melanin, and in what kind? My melanocytes don't make melanin, right? Yours do. Yours are darker pigment, right? So it just depends on your own history and complexion as to what sort of genetics you have and what kind of melanin and how much of that melanin you produce. So skin color is largely from your melanin, but a little bit of skin color comes from, look at this protein name, keratin. Not keratin, like the stuff in our cells, but keratin. This is vitamin A. If you eat enough carrots and take enough vitamin A supplements, or vitamin B supplements, you will kind of become orangey. Your palms will become orangey. So a little bit of your skin color comes from your diet. And then a little bit of your skin color also comes from hemoglobin. Hemoglobin is the protein that carries oxygen in your blood. So you know that when you exercise or it's hot out, your skin becomes redder. That's hemoglobin. When you're cold or you're sitting around, those blood vessels aren't as close to the surface, and so your skin becomes a little bit paler. But for the most part, your skin color is all about melanin from the melanocytes. Now, I also mentioned to you in lab that epithelial cells typically don't have blood vessels. But there are a couple of exceptions, and they're not normal, but they are sort of birth defects or variations. And on the bottom, I've got a couple hemangiomas. Now, hemo means what? Hemo, blood, angio, vessels, oma, we don't have that yet, but tumor or growth. So a hemangioma is what? A sort of like a growth of blood vessels, right? It kind of makes sense when you look at all the terms. Blood, vessels, and structure of some sort. This guy on the top has rather a large hemangioma. Now, likely, that will all be gone before he or she reaches kindergarten. Those are called strawberry marks or capillary hemangiomas. So in that situation, there are blood vessels that are very, very close to the surface, and it almost looks like they would break and bleed, and they could. 4 of my 5 kids were all born with these kind of strawberry marks. Not that large, but a couple had big spots on their chest. One had one in the back of her head. One had one down by the butt. And we were always worried they were going to get cut or broken and bleed. They never did, but they tend to disappear. And by kindergarten-ish, they're gone. No mark of it, nothing at all. But there's another kind of hemangioma called a cavernous hemangioma. These are deeper and they're more permanent. And these are what you're seeing on this little guy in the bottom picture. So this would be more of a permanent birthmark. And this is what Gorbachev had. This is what Drew Brees has on his cheek, right? You always see him from one side. He never shows the other side. So that's a cavernous hemangioma, sort of a large birthmark that is permanent. So that's an exception to the blood vessels being in the epidermis, right, the hemangiomas. Also on your skin, you can have nevises. These are moles. Moles are usually dark in color, aren't they? So they are they are cells that are overproducing melanin. So what layer are they coming from? Where were the melanocytes? They were in the stratum basale, right? So these are overgrowing cells of the stratum basale, the ones that make melanin. right? So it's really, moles are a benign tumor, is really one way of thinking about it. Now, if you have a lot of moles in your body, it's important that you have your doctor checking them every time you have a checkup. They should be measuring them or taking pictures of them. And if they, over time, begin to get larger, darker, more irregular, problem. And so moles should be periodically, if they start to grow, lopped off, sent off to biopsy to make sure there's no cancerous changes. Moles can become malignant. They can become very dangerous cancer-like cells. So they need to be watched. So if you're going to a doctor and you have moles on your back or anywhere, and they're not doing a full, a full disclosure of your body, make sure you let them know that you have moles so that they're watching them, because they can get away and then you've got a skin cancer that could kill you. So it's very, very important. Then there's freckles. Freckles are also areas of excessive melanocyte activity. And typically, kids have more freckles in the summertime. So there's more UV radiation, the melanocytes get excited, and they start putting out extra melanin. So my little guy all my kids, 4 of them don't really have freckles, but my little guy has a lot of freckles all over his face. So lots of freckles, lots of extra active, if you will, melanocytes. Again, not more melanocytes, just more active ones. Now, you also are aware from just everyday experiences and CSI kind of shows that you have fingerprints. Those fingerprints are also called, quote, friction ridges. They are why are they there? They're not there to catch the bad guy, right? The friction ridges are there to help grip things. They help give friction. So when you pick up things, when you walk with your bare feet, you've got this extra little grip, if you will, from these friction ridges. What they are irregular peaks and valleys where your epidermis and your dermis come together. It's very much random. It's not genetic. Identical twins do not have identical fingerprints. So this is kind of just a sort of like a kid going into a paint bucket and swirling paint. It's very much random. No two will be exactly the same. Now, those friction ridges, as I mentioned, help with friction, but they have been used since about 1850 or so by forensics to catch the bad guy. So we know that each person has a collection of these. Do not memorize these. I don't want you to worry about these. But there are arches and whorls and loops and combinations that have been, categorized, and now we have computer programs that can search for fingerprints and look for matches based upon these whirling patterns. So not to memorize, just to appreciate. So that's everything with the epidermis, right? Epidermis, up until now, I talked about skin in general. I mentioned the 5 layers or 4 layers of the epidermis and talked about a few unique things, moles, skin color, things related to epidermis. Anything at all to clarify? Let's go through the layers really quick. Bottom layer, stratum basale. Thickest layer, really, in healthy living cells, stratum spinosum. Cells are still dividing, pushing up. Then they start dying. They start breaking down. They become granular, stratum granulosum. And then in thick skin, we would see a very thin stratum lucidum. If it's thin skin, we wouldn't see it, and we would only see the stratum corneum, the top dead layer of cells. Let's go down to the dermis. So the dermis we know is down below it. It's not epithelial cells. It's instead connective tissues, mostly collagen fibers, right, but some elastic fibers and reticular fibers holding everything together. And it's down here that one finds the blood vessels, sweat glands, those oily sebaceous glands, hair follicles, nail roots, you name it, nerve endings. All that stuff is down in the dermis. Now, this is new. The dermis is actually composed of 2 layers. There's a more superficial layer, the layer up near the epidermis, referred to as the papillary layer. We're going to see the term papilla, in many, many places. And it essentially means nipple-shaped. So what you see here, the epidermis and the dermis come together. It kind of looks like an egg carton, doesn't it? Or a mattress pad cover. It has that peaks and valley look to it. And in the very, very top layer, The papillary layer is just this little tiny bit up here. It's where those peaks and valleys are, where those little nipple-shaped extensions are. So that's the papillary layer. And then below that is the deeper layer, and that is called the reticular layer. So papillary, more superficial, reticular layer, deeper. Most of the dermis is reticular. The papillary layer is very thin. So just, again, a slide for each of these. So the papillary layer is right up under the basement membrane, and this is where that loose areolar is found. Okay, so when you think about the dermis, I told you there's some loose areolar. It is really here in that papillary layer. And this is also where you have some touch receptors. If you look at this picture, I know it's small, but do you see what looks like little yellow arrowheads? Those little yellow, right, nervous system, those are little yellow nerve endings. And they are right up as close to the epidermis as they can get, but they're still down in the dermis. They're down in the papillary layer. And then the reticular layer, again, everything deep to that. The reticular layer is going to go down all the way down to the hypodermis, all the way down to the subcutaneous layer. And this is where the dense, irregular connective tissue is. So you really can think about the two layers having two different types of connective tissue. The papillary layer has loose areolar, and the reticular layer has dense, irregular tissue. One of those you know how to recognize, right? You know how to recognize the loose areolar. You do not have to recognize dense, irregular. Here's a pleasant thought: stretch marks, wrinkles. So what's going on? Stretch marks. No one wants to volunteer to show them, I know, right? But stretch marks, often after pregnancy or after weight gain and weight loss, you'll see stretch marks. Those stretch marks are really where the skin has been stretched beyond its ability to stretch anymore. And what you've done is you've torn collagen fibers. So in the skin, you've got collagen fibers giving strength like fabric. And when the skin stretches, pregnancy or weight gain, weight loss, basically those collagen fibers have a limit and they tear. And those tearing moments create these long, wonderful looking stretch marks, right? And they never quite go away, right? We can put some stuff on them, we can talk about it, but they really never quite go away. They're just a reminder of that kid or of that weight loss, weight gain. Another thing that's a lovely thought are wrinkles. Now, wrinkles are caused by an excessive exposure to UV radiation. This is why, I'll say ladies for most people, but guys too, who sit in tanning booths, right? You may look good right now, but you're going to look like a Shar-Pei when you're 65, okay? Because that extra UV radiation does cause excessive wrinkling. So people who live in the southeast and southwest and don't, wear hats and don't wear good sun coverage will have more wrinkles than other people. Now, there's some genetics to this. Some cultures don't wrinkle as much. Honestly, a lot of Asian cultures, you don't see as many wrinkles. In other cultures, you'll see more. The thickest wrinkles I've ever seen was a woman in Arizona. She worked in the desert at a cactus farm. We stopped at the side of the road to get some cactus, and this woman had the deepest, thickest wrinkles I have ever seen. Dark tanned woman, but just deep, 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 deep wrinkles. So definitely Shar-Pei looking. Now, you mentioned about scars. Your dermis has what is called lines of cleavage. Now, cleavage is a word I used in mitosis. I said that as a cell undergoes cleavage, we see that the cell is dividing. But here, what I'm referring to is the orientation of the collagen fibers. An orthopedic, any surgeon knows this. A plastic surgeon is especially mindful of this. If you look at this guy, you see that there are lines on him, and those lines are the lines of cleavage. In other words, the collagen fibers that go across your mid-chest are kind of straight across. The lines that go through your abdominal region are a little bit more at an angle. The lines of collagen that go down your leg are kind of like a barbershop pole. If you are going to have trauma, you have no choice, right? If you have an accident and you cut yourself and they have to put stitches in, not much we can do about that. But ideally, you want to cut yourself so that the incision on the bottom is running the same direction as the lines of cleavage. Because when they go to staple that or suture that scar closed, those collagen molecules, those collagen lines will more line up with each other and will create a less visible scar. If instead your surgical scar is going perpendicular to the lines of cleavage, then it will pull more. It won't go together as well and will more likely leave a greater scar, and that incision will not heal as quickly or as tightly. So a plastic surgeon, right, is going to make sure that they're going to slice right along the lines of cleavage to minimize the scarring. Right? If you're going in for surgery, they'll do the best they can, right? But necessarily, if they're going after, let's say they're going after your gallbladder, now sometimes they'll go through your belly button, so there's no real scar left. Other times they'll have to go in deeper through your appendix or something like that. So they'll do the best they can to try to minimize the scarring, but you now understand why a little bit more, why some incisions will heal better. It's just they're along the line of cleavage. And in the dermis, lots of nerve endings. If you look back at that first picture I showed you, there are lots of yellow nerve endings in the skin. They have different names. We'll deal with them later. Okay, I just want you to know there's lots of nerve endings in your dermis. Lots and lots. And all your blood supplies down there as well. Okay, lots of blood supply. Vasoconstriction, vasodilation. Vaso means vessel. So I've already said this, when it's cold outside, what do your vessels do? You're trying to conserve heat, trying to conserve. So they're going to get smaller. They're going to vasoconstrict. They're going to have less blood flow going to your skin, and so you'll become less colorful and more pale. And when you're hot and sweaty and exercising, those blood vessels are trying to get off heat, so they'll open up, they'll vasodilate, right? Vasodilate. I'll just say this. What do you think happens to your blood pressure when it's cold outside? Goes up. Why? All the blood from your skin surfaces is kind of being taken away from your skin and is being sent, right, to the center of your body. And so with that more fluid going to the center of your body, your blood pressure will go up, right? So if you just took your hand and stuck it in an ice bucket and you're checking your blood pressure at the same time, you would see your blood pressure goes up, in part because it's cold, right? Or you walk into a cold room, right? And your blood pressure will actually go up. Your blood pressure will also go down if you go in a sauna. So a sauna, not only is it relaxing and warm, but literally more blood is going to your skin, and therefore there's less fluid in your core, and your blood is spread out more, so it has less pressure on your vessels. So that's the dermis. Now the hypodermis. Okay? Pretty boring, actually. It's just the layer deep to the dermis. Again, it's not officially part of the skin. And it's made up also of that loose areolar and quite a bit of adipose. Now, how much fat you have here is somewhat related to your exercise and your body's condition. But where your body accumulates fat is pretty much genetic and sex-related. So women tend to have fat on certain parts of their body, certainly breasts, men not as much. But also, just go to the mall, right, and watch grandma and mom and grandchildren walking down, and you'll notice that those with bigger hips, they all have bigger hips, right? So there's very much a genetic component to where the fat accumulates. My poor daughters, we love my mother-in-law dearly, great mother-in-law, but she had this double chin thing. And no matter how thin my girls are, they have Grandma Strunk's chin. Right? There's going to be just a little extra skin and fat that accumulates right underneath here, and they just look in the mirror and say, "Thank you, Grandma." So there is a genetic switch, if you will, as to where we accumulate the fat. Not much we can do about it, except it does keep plastic surgeons really busy, right? I don't like Grandma's chin. Okay, we can fix that. Give me $5,000. So that's the hypodermis. Now, let's take a look at have a good week. Let's take a look at nails. Now, you know that the nails are part of the integument, right? Nails and sweat glands. I'm not going to have you worry too much about the structures of fingernails. I didn't even have you label that in your pre-lab. I told you to skip over all that stuff that was in that section. But I do want you to realize that your fingernails are really just an extension of your epidermis, specifically of keratin. So the major protein that makes up your fingernail is keratin. It's the same waterproofing protein. And, you know, we have fingernails for a reason, right? They help us grab onto things but they're really a hard keratin derivative from the stratum corneum, right? Those are the cells that are filled with keratin. So, all I want you to see right here, here's the fingernail coming out, right, through here. And it literally is just an extension, I'm not going to be label this or anything, but it truly is an extension of the stratum corneum. So it's always growing, always being pushed out by the skin. You also have this really cool little area, I'll just say it for words, lanula. Okay, the lanula. And the lanula is that little area on your fingernail that has a slightly different looking vascular supply. And you'll see that little area. Okay, kind of a neat little area. But that's it. Don't worry about the parts of the fingernail. I'm not going to quiz you on them at all. Hair, another part of the integument, pretty much found everywhere, like I said, except soles, palms, genitals, and most of the hair, although we think, oh, you have most of your hair on your head, actually, there's more hair on the rest of your body. It's just that it's spread out and very fine. It's just more concentrated on your head. Each single hair is called a pilus. A pilus. So why do we have hair? Protects. First thing we do with a newborn is stick a hat on their head, right? So it helps to retain heat. So the hair, if a baby's born with hair, they don't have to put the hat on quite as much because we don't lose quite as much heat when there's hair there. Clearly you can, if somebody just barely touches you, or they don't even touch your skin, but they touch the hair on you, you know it because there are at the ends of every single hair a little nerve ending. So when the little hairs get bent, you know it. There's little nerve endings. So it's all about touch as well, sensory reception. We recognize people in part by their eyebrows and eyelashes, and hair, along with the sweat glands around them, do send out chemicals called pheromones. There used to be an argument, I guess 20, 30 years ago, that animals sent out pheromones, right? Pheromones were chemicals that influence sexual performance and attraction of animals. And there were people who thought, well, humans don't have pheromones. Yeah, now we know that humans also do have pheromones. So humans do send out chemical signals. In fact, each of us probably has as much of a unique chemical signal as we do a unique fingerprint. And we're learning more about that. There are 3 kinds of hair on your body during your lifetime. A newborn, especially a preemie, if you've ever seen a preemie, they're born with a white, downy layer of hair on them called lanugo. And it's usually gone before birth. So you won't see lanugo typically anywhere on your body or never would have. Vellus is the name for the hair all over your body. So again, most of your hair is kind of spread all over you. That's vellus. And then there's terminal hair. This is the hair. It's kind of different. It's thicker. It's the hair of your scalp, the hair of your eyebrows and your eyelashes. This is also the hair that begins to grow in the pubic and axillary regions at puberty, as well as facial hair in guys. Okay. And I guess in women too, right, if they have facial hair. We're not going to get too excited about this, but I think it's interesting. This is a hair, this is a little bit of skin, right? And this is the hair follicle, and this is called the root of the hair down here, and we see the hair going up. This is the muscle. This is cool. Every single little hair you have on your body has its own little muscle, okay? A little smooth muscle. And that little smooth muscle will contract and pull, and when you're scared or cold, that will pull the hair up. Isn't that cool? Every little hair, millions all over your body, have your own little smooth muscle that do that. Those are called the erector pili muscles. Erector, pull your hair up. Pilus, hair. Right? So the erector pili muscles. And at the very bottom of this hair, it's hard to see here, but there's nerves down here. That's why every time you touch the hair, you know it, because there's nerve endings at the bottom that give you that sensation of touch. There's also down here some melanocytes. What are they doing? We saw melanocytes in the stratum basale giving skin its color. These melanocytes are the ones that give you hair color. Again, genetically determined. So your hair, your melanocytes are making the pigment of your hair. Now what happens to the hair pigment as we get older? Poops out, right? So after a while, the melanocytes get tired of making their protein, and the hair can turn white or colorless. So that's easier to see right here. In fact, I just want you to see this word, hair papillae. Again, nipple-shaped, right? So this little nipple-shaped structure that goes up, and that's where the nerve endings are and those melanocytes. And this shows you just how our hair looks under electron micrograph. So there's a hair coming up, and now you can kind of really see how dry and flaky those cells are on the surface of your skin. So hair color. I've already mentioned the melanocytes. They're down there making the protein that gives you your color, red, or really blonde is an absence of, or very little color. Black hair, brown hair, a different combination of color. And what can cause hair color to change? Age, for sure. Hormonal changes, pregnancy can change color of hair and can change texture of hair. Some kids are born with very light blonde hair and then become darker in color. So there's all kinds of reasons why our hair color can change. Gray color is a reduction in melanin. So my hair is getting more gray. And when my hair is completely white, then I no longer am making any pigment at all. Your hair you're always losing hair, but you really shouldn't be losing more than 100 hairs a day. That seems like a lot. But in your brush and in your bed and everywhere else, you're losing 10 to 100 hairs a day. That's normal. Hair's growing about 1/3 of a millimeter per day. After a while, really, really, really long hair stops growing as much. Okay, but if you cut your hair, it's like cutting a shrub. It kind of kicks it up again. And a hair that's very, very long really does start to slow down. If you are losing more than 100 hairs a day, then you could be under stress. You could have been exposed to radiation. You could have some dietary issues, hormonal things. People who have gastric bypass surgery lose a lot of hair because they don't have the nutrition for a while, and then it usually recovers. People with radiation treatment for cancer, they'll lose hair. But if you lose hair, it starts to thin out. That's called alopecia, and that is, guys, it's more common, right? Alopecia, but a little bit more devastating in women when they have thinning hair. I mentioned that we do produce smell. This is a hard picture to find on the internet, but we do make sweat, and we make sweat from different sweat glands. We have all over our body normal old sweat glands. These are called merocrine. Can you go back and remember what merocrine meant? The cell stays merry. It's simply releasing its products. It's a very watery type of secretion. So all over your body, especially your hands, you have tons of these regular merocrine sweat glands. You have up to 500 glands on every square centimeter on your hands. I mean, you have a lot of little sweat glands on every little piece of your hand and feet. Mostly water, right? 99% water, a little bit of salt. But you also have sebaceous glands. These are the sebum, oily secreting glands, and they release their products through, that's the next page, isn't it? I'll come back to this in a second. Apocrine. Apocrine were the ones that were kind of in the middle. I introduced apocrine as being like milk production, but you also have apocrine glands secreting sweat from your axilla, armpits, areolar around the breast, and also the pubic regions. These are different sweat glands. They produce different sorts of sweat, and bacteria love these secretions, and that's what gives you your body odor. This is not the good body odor, right? So this is the stinky body odor that accumulates on us. And again, each person probably has a unique set of chemical signals that one could determine. So those are apocrine sweat glands, more in the armpit and pubic regions. Look at this picture. This is a slice of skin, and I want you to see this little guy over here, this purple sweat gland. Notice it's going straight to the skin, right? It's going straight up. The little duct brings it right up to the skin. That's going to be your common type of merocrine sweat gland. Then notice that there's this gland. This one is an apocrine sweat gland, and look what it does. The tube brings the sweat up right next to a hair. So this is the kind of sweat gland I just told you was in higher concentration in your armpits and in the pubic regions, and where you have more hair, right? And these are the ones that put out the stinky kind of sweat. Finally, though, there's also sebaceous glands. This big thing right here that's around the hair follicle, that is the sebaceous gland. That's going to be the kind of gland that releases the oily kind of secretions. So here's the sebaceous glands. These are the ones that are really, really, I guess, the culprit for boils and a lot of acne. Now, this is just a cartoon picture, of course, but these sebaceous glands are producing sebum. Oops. They're producing sebum. That's the oily stuff. And remember that these are releasing through holocrine. That's a typo. It should be H-O-L-O. Holocrine secretion, not halo. Holocrine secretion. Remember, that's where the whole cell dies and kind of gunks up the sweat gland. But as we've already said, we want some oil on our body. We want our skin to stay supple. But with that, we pay a price. So we can have some sweat glands that get clogged up like acne or boils. Now, these are inactive until puberty. Right? At puberty, kids start to stink. Right? I mean, an 8-year-old can run around all day, be all sweaty, get in the back seat of the car, and you really don't smell them. When they get about 11, 12, 13, things change. Right? So with puberty comes the onset of these oily kind of secretions with acne, as well as facial or axillary, pubic hair, and that also brings on the sweaty kind of apocrine secretions.
So with dry skin, does that mean that they have less sebaceous?
Absolutely. Fewer sebaceous glands. Now that happens with age, right? As we get older, our skin naturally gets drier. That's why people are putting on more lotion. And I'll get to this at the end, but do grandma pinch test, right? Some older person, just take their hand and be very gentle to them, but pinch the skin on the back of their hand, right? Now in your hand, go ahead and do it. The skin should release back very, very quickly, right? It goes back. It has a lot of elasticity, and it's very supple, and the skin goes back to where it was. On grandma, you pinch, and it might just stay there for a while. Mine's getting kind of slow. I'm a little worried, right? So it just takes a little longer for it to return because the skin is drier. It is not as supple. It's losing elasticity. There's more wrinkles. The collagen starts changing. So yeah, that's all connected together. The other thing that oil does is it helps to reduce bacterial infections. So as you're making sweat, it's actually helping to catch bacteria and release them from the surface of the body. I am not going to have you worry about histology. So let's put a big old X right through that slide. Don't worry about the histology of sweat glands. Now, the other things that are included here in the integumentary system would be your ceruminous glands. Cerumen is earwax. So these are the glands that make the lovely earwax in your ear canal. And aren't we glad that they're only there? Can you imagine if you were making cerumen other places on your body? Ew, right? We're glad it's stuck in there. Now, cerumen is important. It does help. Basically, it's sweat glands that make this stuff in your ear canal. And it does help to clean out your ear. And this stuff comes out. It stops things from getting into your ear as well. So it's really meant to be protection against damage to your ear. And then mammary glands, milk production. They are also epithelial glands. And they are modified apocrine sweat glands for the production of milk. And that milk is produced under hormonal signals. And we'll talk about those hormones when we get to the endocrine system and to the reproductive system. Okay, so that brings us to the end of skin, honestly, and all the things related to the integumentary system. Any thoughts or questions? Anything on the dermis? Anything on the hypodermis? I think it's a pretty straight, I mean, there's some things to learn, but it's a pretty straightforward system to start with. I want to share with you just a few slides on burns, and then we'll finish it with skin cancer, and we'll be done a few minutes early today, which is good. We'll finish with that. So burns, major problem, right? Major cause of accidental death in kids, and I don't know what is this even in your book? I see you flipping. This may not even be mentioned in your book. This may be a little extra, little extra infomercial. And I like burns. Well, don't like being burned, but part of my doctoral research was in wound healing, and we would burn pigs. Pig skin is closest to human skin of any animal. And we would burn pigs. Actually, we'd make this big grid on their back, big old sows. Make big grids on their back, burn them, and almost like a branding iron type thing. And then apply different chemicals to the areas and look to see which ones, healed faster and that kind of thing. So it's good. It's all good. But burns can be caused by chemicals, by electricity, any kind of thing that can damage it, even sunlight, right? We can all have a sunburn. And the problem with burns is that immediately, if you lose a lot of skin, you have the ability to lose fluid. If you're losing a lot of fluid from your body, what's dropping? Blood pressure. Right? If you're losing a lot of fluid from your body, your blood pressure is also going to drop. If you lose too much fluid, and your blood pressure drops too low, then the brain will no longer get the oxygen that it needs. So the first, the real critical thing at first is fluid loss, and then once you get the fluid loss under control, you still have opened your body to infection. So some people will survive a burn, but then will die of a massive infection because they couldn't keep it under control. So a couple really significant problems. And then, of course, the healing process can be very, very difficult and very, very painful. So burns are tough. Now, there's 3 different layers of burns based upon how deep the burn is and what layers of tissues are involved. First, second, and third degree burns. First and second degree burns are called partial thickness burns, because they only partially go through the entire skin. Okay, they're not going all the way down. Third degree burns are called full thickness burns because they're going to affect all of the dermis and all the epidermis. They're going to go through both layers of skin and completely destroy it. Some people will talk about 4th degree burns. I do not know that it's a legitimate classical term. 4th degree burns usually are just a really bad 3rd degree burn. It means that the person can see bone underneath the skin. So we've gone all the way down to bone and muscle. But usually 3rd degree burns the same way. So really 4th degree is not really a good clinical term, but you may hear it said. It just means a really, really bad 3rd degree burn. So let's take a look. Let's take a look at some pictures of these. Question?
You can see bone.
You can see bone and muscle. You have, the skin is gone, fully gone, full thickness gone, third burn, 3rd degree. So 1st degree burn, sunburn. That's really all it is. And all you have damaged is the epidermis. So you've destroyed part of, not even all of, you destroyed part of the epidermis. Skin gets red. It's painful, definitely painful. A little bit of swelling maybe, but that's it. Okay. So sunburn. And if you look in the cartoon, it's showing that it's just the epidermis that's been affected. 2nd degree burn is going all the way through the epidermis and is including part of the dermis. It is characterized by blistering. So if you have a blister, that is 2nd degree burn. This is curling iron on the forehead, right, ladies? All right, maybe. That's a blister burn. Touching the stove, a little blister, 2nd degree burn. You can get 2nd degree burns from the sun. As a kid, I'm very fair. And as a kid, I can remember getting big quarter-size blisters on my back just from being in the sun. and maybe some with fairer skin are saying, yeah, I've had that too, right? So you outside, or even little tiny blisters, that's the beginning of a second-degree burn. You know that you've gone all the way through the epidermis, you've actually gone down into the dermis. It's still considered a partial thickness though, isn't it? Okay. Third-degree burn. Oh, and because you went down in the dermis, it really hurts, right? These hurt because what have you done? You're turning on and activating all those nerve endings that are down in the dermis, so it's very, very painful. Now, third-degree burn is where you have completely wiped out the skin. You've wiped out all the epidermis and all the dermis, and not painful. Because what have you completely destroyed? All the nerve endings. So the nerve endings are gone. Now, that is not to suggest that around the edge of the burn it hurts like heck. So imagine you've got a big crater kind of burn on your arm. So in that area where you have a third-degree burn, in the core of that burn, it would be painless. All the nerve endings are gone. But around the edge, it'd be more of a second-degree kind of burn, and there would be a lot of pain. So it's only going to be painless in the area where everything is destroyed. Here are some pictures. So across the bottom, on the left-hand side, good old sunburn, right? So that's first degree. Blistering, second degree. This really doesn't say much here, but this is just a lot of scar tissue. That would be a third-degree burn. Now, third-degree burn, when you get a burn, or when you get a cut even, let's just think about a cut, how does it heal? If you have a scab, right, or a burn, same kind of thing, you notice that the scab gets smaller and smaller. It grows in from the edge and maybe even up from the bottom layers. It kind of gets less cavernous, right? Less crater-like. So it becomes not as deep and smaller as it heals. If you have a third-degree burn, you no longer have anything from the bottom to grow back up. You've lost all of your skin regeneration abilities. So a third-degree burn will not just regenerate. It requires a graft. So a skin graft is basically taking a piece of skin from somewhere else on your body, usually, and placing it on top of that third-degree burn. So they take basically like a cheese slicer grater, slice some skin off somewhere else in your body, and lay that skin over the wound. And it will usually take, kind of like a grafting of a plant, it will take and replace. Now there's going to be a lot of scarring involved, and that's why people with third-degree burns must have a lot of physical therapy, because otherwise the scarring can be very devastating, especially if it's in a near joint. So people who have a facial burn along the neck, if they don't get a lot of physical therapy, their neck will be stuck down like this because that scar tissue will hold them down. So they have to get physical therapy to keep that skin loose until it fully forms. Or a person who has a big burn on their arm, if they don't get physical therapy, their whole arm could be contracted because of the scar tissue, and they've got to get a lot of physical therapy to keep it mobile until it completely heals. So that's a big issue. Burn issues are huge. So I definitely want you to know first, second, third degree, what layers are involved, and if someone were to go into the emergency room with a significant burn, there's usually a chart on the wall of an emergency room that will give you some of this information. Now, there's 3 risk factors for a burn. How old you are. If you're over 60, you're at higher risk. How much of your body was affected. If you have a serious burn to more than 40% of your body, that's a lot. That's a risk factor. And thirdly, did you, in the accident, also suffer inhalation damage? Was there smoke where you suffered some respiratory damage as well? If you go to the emergency room with a burn, but you don't have any of those factors, you're less than 60, it's less than 40%, and you didn't have any smoke inhalation, there's only a 0.3 chance, and that should not be 0.30, like 30%, but 0.03, or 0.3%, sorry, 0.3% chance. There should be a percent after that. 0.3%, very small chance, right, of dying. You're going to be fine. If you have one of those risk factors, let's say you're over 60, 3% chance of death. That's okay. You're going to be okay. If you have 2 of those, 33%. So if you're over 60 and maybe you're in a car fire and there was smoke, or a house fire and there was smoke involved, and you're over 60, even if you didn't have a full part of your body covered, you still have a pretty good chance of dying from those injuries. And if you have all three, you're older, large percentage of your body, and suffered smoke inhalation, 90% chance of death, right? So pretty serious combination of factors. So just kind of know those numbers and know those three risk factors. I may have a case study. In fact, I will have a case study on the exam, and some young woman is going to have a burn, and you'll be describing what kind of burn is based upon the damage, first, second, or third degree, and you'll tell me her chance of dying based upon her risk factors. Okay, so just know those little numbers. Last thing. Oh, two things, sorry. Acne. That's a lovely thought. Then we'll get to cancer. So one more thing about skin. Acne. They're also called comedos, right? Not that they're comedic, but comedos. And there's two kinds of acne. We know this, blackheads and whiteheads. Blackheads basically are where it's a sebaceous gland, right, an oily secreting gland, and it is plugged with sebum, oil, but it's open to the surface. So a blackhead is open to the surface, whereas a whitehead, it's still a plugged up sebaceous gland, but it's still underneath the surface. It's creating more pressure, and that's a whitehead. So that's really the only difference. I was looking for some lovely pictures of blackheads, so I found this picture, and we can see some blackheads here around his nose. This is a cartoon of a blackhead. Again, it's a plugged up gland, but it's open to the surface. Then here is a whitehead. It's still underneath the surface, more pressure. We see the white. I looked up whiteheads online, and I found this picture. So this is the whitehead family. Kind of. Last thing, what happens to your skin as you age? Right, a few things. They're kind of obvious. We've already mentioned some of them. So number one, it'll take longer to repair. Cut yourself, it's going to take longer to heal. There's fewer stem cells deep in your skin to help repair. Number two, more wrinkles, right? Your skin will become less supple. They'll have less elasticity, a little tougher. There'll be fewer of those Langerhans cells. So if you get a bacterial infection in your skin, they won't be able to get rid of that infection as easily. The skin becomes drier because there's fewer sebaceous glands. And there can be a change in pigmentation. Liver spots, and I'm getting a few, on the back of the hand especially, are dark areas, kind of like freckles, that are related to age and exposure to UV radiation. Sweat production diminishes, so you start sweating less, and blood control going to the dermis changes. So this is why older people are always complaining about it's hot, it's cold, it's hot, it's cold. They don't have the thermal regulation. They don't have the vasoconstriction and the vasodilation going on in their dermis as much. And so they have issues with regulating their body temperature. Hair follicles will produce thinner hair or none at all, and that hair may change colors, that is, become more gray. The skin will also stop making as much vitamin D. And without as much vitamin D, your bones can become more brittle. So with age comes also things like osteoporosis, in part because the skin is not making vitamin D, and vitamin D is important for your body taking calcium in. And with time, you can develop skin cancers. Okay. So I do have one slide. I keep saying it's the last slide, but this is truly, I think, the last one with the picture. So skin cancer is the most common type of cancer. And it is greatest for individuals who have had exposure to UV radiation, especially younger in life. So I know I'm at a higher risk for skin cancer. I'm fair in my complexion, and I had a lot of serious second-degree sunburns as a kid. So I know when I go to the dermatologist, when I go to my doctor, I take everything off. And I spin around, and I say, take a look. Because there might be something back there that I can't see. And these skin cancer changes are very slow to develop. And you may not notice it by looking in the mirror that over the last year, this thing has really gotten bigger. It has really changed. And you may not notice it. So it's really important, if you have fair skin and a history of sunburns or a family history of skin cancer, that when you go to the doctor, you don't just do a drive-by physical, that you actually take your clothes off. I've gone to the dermatologist for facial acne, and they'll say, do you want us to do a back check? I'm like, yep, do the whole thing. All right, let's take it all off, because I just don't want to take any risks. Here's what you want to be looking for. 3 kinds of skin cancer. Basal cell carcinoma. Maybe you've heard of that. You tell me, what cell has gone crazy and made cancer? A cell from the stratum basale, basal cell. So these cells, this is the most common type. The good news is they seldom metastasize. So this is the kind of cancer you want. If you're going to get skin cancer, pray for this one, because this one tends to stay put and can usually be taken off very easily by radiation and surgical removal and doesn't spread. So this is the one you want if you're going to get a skin cancer. Number 2, malignant melanoma. This is not the one you want. This is the most deadly of skin cancers. Now, it's coming from melanocytes. Now, melanocytes are also what? In the stratum basale. But we told you that the melanocytes were the ones making the pigment. These are the cells that can be a mole and then can become a very serious cancer. So if you have moles, have them checked, because they can become malignant melanoma. And this is scary. This stuff kills people. So a little mole can kill you. So watch it. And again, higher risk for people like me with skin cancer, or with a history of sunburn. And then finally, squamous cell carcinoma, kind of in the middle. They're going to be, you can tell me what kind of cell they start from. The flat cells up from the stratum granulosum areas. And these are going to be typically on the scalp and the back of the hand, places where you'll usually see them. And they can metastasize, so that's dangerous. So what do you want to be watching for? A, B, C, D, E. A, asymmetry. If you have a little mole or a little spot on your body, and it's symmetric, it's perfectly round, it's okay, more likely. If it becomes ragged or irregular or asymmetric, concern. Number 2, border. Does the border of the mole or the border of the spot start getting ragged? Does it start changing its edges? Number 3, does it start changing colors? Does it get darker or lighter? Number 4, is it changing in diameter? Is it getting bigger? Number 5, is it growing in elevation? Is it getting bigger from the surface? A, B, C, D, E. Those 5 things are important. So if you have a mole or someone in the family with a mole and you see those kinds of changes, you want to be alerted to it, have it checked out, and this is why your doctor should be taking pictures and noting all of your moles so that you can notice those small changes over time. Well, I said we'd be done early. I lied, apparently. Right on time, right? 1 minute over. And that finishes up the material for the exam. Now, that's quite a bit. The skin, though, is pretty friendly. It's not too tough. Do the homework, do the mastering assignments, take the quiz, and I think you'll be very successful next week. That's all we'll do during the exam. You'll need your 884-E form and a pencil, and that's all you'll need next Monday for class.